Good afternoon. So this was a 62-year-old woman with multiple lung nodules. The patient was a 62-year-old woman who was a former smoker, and she presented with chronic cough since October 2016. She was treated with several cycles of antibiotics and steroids, which didn't resolve her symptoms. A chest X-ray showed a suspicious lung nodule, and then the CT of the chest also showed multiple nodules of varying sizes, but she did not have significant lymphadenopathy. Multiple biopsies were attempted. They were all non-diagnostic. The patient came here. A PET scan showed a posterior right lower lobe lung mass, which was pretty sizable. And she also had innumerable lung nodules. She underwent a wedge resection of the right lower lobe of the lung. This was the chest X-ray that showed the nodule in the right lung. And a CT of the chest showed the multiple bilateral nodules, most prominently at the bilateral lung bases, with areas of associated ground glass opacity. So this was one of the sections that we got for evaluation. As you see grossly also, there's this large area of central necrosis in the lesion, in the nodule. There is a viable rim of tissue, and then there is the uninvolved lung, as we saw in the low power of the microscope. So the necrotic areas show ghosts of cells upon higher power. This is the cusp of the necrosis in the bottom, and also the inflammatory infiltrate, the viable rim of the tissue right next to it. We did not see palisading histiocytes or granulomas. And this viable rim of tissue was composed of a polymorphous lymphohistiocytic infiltration of predominantly small lymphocytes. There were histiocytes within the infiltration, and there was an increased number of vessels. We did not see eosinophils or neutrophils or granulomas. In other areas in the lesion, we noticed that the blood vessel walls were infiltrated by predominantly small lymphocytes. The angiodestructive and angioinvasive infiltration was prominent. And at high power, we noticed that there were these scattered large cells that were atypical with prominent central nucleolus. And again, the background, majority of the cells were small lymphocytes. Again, one of the large cells. So we did some immunohistochemical studies. CD20 highlighted at low power that there were these patchy areas of confluent sheets of cells. These were corresponding to those ghost cells, basically, which showed a differing intensity in CD20 expression ranging from anywhere from negative to weak to bright. Again, we identified those large B cells in the blood vessel walls with CD20. Further immunophenotyping showed that many of those large B cells were positive for CD79A, another B cell marker. And the T cell marker CD3 highlighted the predominant small T cell infiltration in the blood vessel wall, and majority of these T cells were CD4 positive with less numerous CD8 positive T cells. CD30 immunostain highlighted most of those B cells, or the large cells, I would say. CD56 was negative, and Ki67, the proliferation marker, highlighted majority of those cells. And finally, we did an in situ hybridization for WHER, highlighted numerous cells that were invading the blood vessel walls. So based on all the findings, our diagnosis was lymphomatoid granulomatosis grade 3. So what is lymphomatoid granulomatosis? This is considered as an angiodestructive and angioinvasive EBV-associated B-cell lymphoproliferative disorder, which has been initially described by Dr. Libov in 1972 in his seminal paper. He described 40 cases, and his morphologic description and the initial impression still remains the same for the entity. And Dr. Libov has suggested a possible viral etiology in lymphomatoid granulomatosis, and it took several years before Dr. Katzenstein actually showed EBV genomes in the LYG using PCR technique in 1990. And finally, in 1994, Dr. Don Gini, who actually happened to be the first pulmonary pathology fellow of Dr. Travis at AFIP, he showed that the EBV infection was present in the large B cells in LYG setting using the in situ hybridization study. So LYG is a rare angiocentric, angioinvasive, EBV-associated B-cell lymphoproliferative disorder, and it was first included as a distinct entity in the 2001 WHER classification of hematopoietic neoplasms. It is considered as a lymphoproliferative disorder of indeterminate malignant potential. Lung is involved virtually in all cases, followed by brain lesions, liver, and skin. Grading has been used for risk stratification and for the treatment purposes, and this is based on the cellular composition of the lesions, the cytologic atypia and necrosis, and most importantly, the density and the number of EBV-positive large atypical B cells. The greatest difficulty is in diagnosing the grade 1 lesions, and it is still uncertain whether LYG represents a unique entity or is part of the spectrum of the EBV-associated B-cell LPDs. In WHO 2008, this was the recommended grading schema based on the EBV-positive B cells per high-power field. In grade 1, basically we see less than 5 cells. In many of those grade 1 lesions actually may not show EBV expression. Grade 2 can show 5 to 20 and focally up to 50 cells per high-power field. And in grade 3, we expect to have usually more than 50 EBV-positive cells per high-power field. This may seem conceptually reasonable. However, on practical level, there are some difficulties. One of them is that the grade can vary from one nodule to the other in the same patient. And then the grade can also change during the disease course. And number 3, because of the marked necrosis, the RNA preservation is pretty poor, and the EBV expression may not be seen falsely. Dr. Katzenstein, in her 2010 review of the LYG, recommended that maybe it is time to call these cases not LYG anymore, but for the grade 2 and 3 lesions, maybe using the term lymphoma would be preferable. So we can think of LYG as a spectrum, basically, ranging anywhere from the inflammatory conditions on the most benign end of the spectrum and the EBV-associated DLBCLs on the high end of the spectrum. So based on the inflammatory cells, the LYG lesions basically show the most polymorphous infiltration. They may or may not show really scattered large B cells, and then the EBV expression may or may not be seen. And this is the most difficult grade to diagnose, basically. And before diagnosing LYG1, all the inflammatory conditions and all the other possible tumor neoplastic conditions need to be ruled out. And LYG2 and LYG3 are much closer to the EBV-associated DLBCL. However, they still carry these unique histological features of angiodestruction and angioinvasiveness and the rich T-cell background. So the WHO 2017 book just came recently, and surprisingly, LYG remained untouched. So it's pretty much the same description, and the chapter remains the same. There are no new genetic information discoveries made in this entity. So the differential diagnosis of LYG includes several things, and the most important differential would be an extranodal NK T-cell lymphoma of nasal type. Both of these entities, LYG and NK T-cell lymphoma of nasal type, may involve the ENT, the head and neck area, basically, and lung. And also, the NK T-cell lymphoma would show angiocentricity and necrotizing areas, and they will also be positive for EBV. However, the atypical, the tumor cells are CD56 positive cytotoxic T cells or NK cells in this setting. So this will be the #1 lymphoma differential diagnosis, basically. Also, PTLD, the post-transplant lymphoproliferative disorders, can present in the lung. However, these lesions, by definition, would have a transplant history. And morphologically, they're not going to have a rich T-cell background, and they're typically not angiocentric. On the benign side, Wegener granulomatosis is an important differential diagnosis. However, Wegener is, although it is angiocentric, it is EBV negative. And typically, you expect to have neutrophilic microabscesses, which is not seen in LYG, and we didn't appreciate in our case either. And there's no prominent lymphoid infiltrate. Hodgkin lymphoma can rarely present in lung as a primary presentation, and it can show also marked necrosis. The tumor cells would be 30 positive, and they can be EBV positive. However, the tumor cells, we expect them to be positive for 15 in 80 to 85% of the cases. And the background would show eosinophils and plasma cells, which we don't typically see in LYG. And the garden variety DLBCL can also be seen in lung. Some of them can be EBV positive, but typically they are not angiocentric. And even when they show necrosis, they can show more apoptotic debris rather than this coagulative necrosis of LYG. And when we see a prominent T-cell infiltrate, we call those cases as T-cell rich, histiocyte rich, large B-cell lymphomas, and those cases are typically EBV negative. So this is the work of the LYG. The clinical features are important to consider when you're looking at the slide, basically. And then the imaging studies would be important. A diagnosis of LYG can be made in the wedge biopsy. The core biopsies would be just extremely difficult, too dangerous to make a diagnosis of LYG. And this is the immunohistochemical panel that you can start initially, and you can expand, basically. Now, the clonality studies are not required to make a diagnosis of LYG. We don't typically run the PCR to see if they're clonal or not. But when people have done studies, it has been shown that ranging from 8% to 69% positivity has been seen. And this is also based on the number of the B cells, basically. In the grade 1, we don't typically see too many large B cells. In grade 3, you're going to have these confluent sheets of large B cells. And T-cell receptor gene rearrangement may be needed in those really very difficult cases of extranodal NK T-cell lymphoma versus the LYG diagnosis. So in that case, T-cell gene rearrangement may be needed to rule out the T-cell LPD. So a good quarter to half of the patients with LYG would also show skin involvement any time during the course of the disease. Sometimes when the disease is quiet, the patient may present with skin lesions. And our patient also presented with diffuse erythematous rash 3 months after the initial presentation, or 3 months after the diagnosis of the lesion in the lung. And this was a skin biopsy that has been recently seen here in our department. The epidermis was uninvolved, and there was a superficial and mid-dermal, periadnexal, and perivascular lymphohistiocytic infiltration. Immunohistochemical studies were done. CD20 was entirely negative, and EBER was negative. And CD3 highlighted numerous small T cells in these dermal infiltrates. Now, LYG involving the skin is a little bit questionable subject. Usually, the skin would show non-specific findings in most of the cases. However, some patients may show subcutaneous panniculitis with necrosis. And it has been traditionally reported that EBER is less often positive in the skin lesions than the lung. And the skin lesions do not coincide with the active lung disease. And we don't really see a skin-confined LYG. So those skin lesions would be seen in the patients that are already diagnosed in the lung, basically. So all these actually features are raising the possibility that the skin lesions might possibly be an epiphenomenon, and maybe they carry a different pathobiology, but not necessarily a lymphoma involving the skin. And when the skin biopsy is the initial biopsy that are showing features that make you think of LYG, other EBV-associated B-cell LPDs need to be considered. So brain is also another common location for LYG. It is seen in about a quarter of the patients. And the diagnosis would be made by imaging studies. This is a typical MRI of an LYG in the brain, showing a centrally necrotic, rim-enhancing lesion with associated edema. And in those rare cases when the biopsies are performed, the typical LYG morphology would also be seen in the brain with this polymorphous lymphohistiocytic infiltration with scattered large cells. And the large cells are positive for 20, and they would show expression of 30, and EBER is shown here in the nuclei. So what is the treatment for lymphomatoid granulomatosis? The prognosis has been very poor historically, and the treatment has been chemotherapy and steroids with a median survival of 14 months. Now, more recent prospective clinical trials at NCI has used interferon alpha for LYG grade 1 and 2. And for grade 3 immunochemotherapy, basically dose-adjusted EPOCH-R, which they also use here in our institution for this setting. This kind of treatment actually really improved the survival of these patients significantly. In LYG 1 and 2, the progression-free survival went up to 56%, and the median follow-up was about 5 years. And in LYG 3, it went up to 44%. So this is the fact sheet. Basically, LYG is a high clinical suspicion when you see a lesion. You need to think about that, especially patient presenting with multiple lung lesions in the lower lobes. Something that needs to be kept in mind is that these patients do not have involvement of spleen, bone marrow, and lymph nodes. So if they say that the patient has lymphadenopathy and multiple lung nodules, it's probably not LYG, basically. There is no clearly defined underlying immunodeficiency state associated with LYG. However, in careful workup, some immunodeficiency states may be seen. And the histology is very typical: the angiocentricity, angioinvasiveness, the polymorphous infiltration, the prominence of the T cells in the background, necrosis, the presence of EBV. And one thing to keep in mind is that these patients have either normal or mildly elevated EBV viral load that might help to differentiate it from other things such as PTLD, like those patients would typically have high EBV viral load. And I just would like to thank Drs. Dogan, Rosenblum, and Dr. Travis for their contributions.